Welcome to our forum on vascular access. Good afternoon, wherever you are, or good morning. If you've been in dialysis for maybe decades or even months, you will agree with me that vascular access is a topic that is dear to the heart of both patients and their families, as well as dialysis providers. Our topic today is on vascular access in the 21st century. However, we cannot have a full appreciation of what we have in the 21st century without any information of the past. Hence, we will look at the present, past, and future. With me this afternoon to discuss this very important topic are three experts in the field of vascular access: Dr. Elsie Koh, Anne Preston, and Dr. Murat Sor. Rather than me introducing them from a script, I would like to introduce them to introduce themselves, to say a little about who they are and what they do. And I would like to start with Elsie. Elsie,
Hi.
you want to introduce yourself?
Thank you, Seth. Thank you so much for having us. My name is Dr. Elsie Koh. I'm an interventional radiologist in New Jersey. I'm the former Chief Medical Informatics Officer and Regional Medical Officer of Azura Vascular Care, and currently now the Chief Medical Officer of American Endovascular and Amputation Prevention, and also the founder and CEO of Lead Physician and Online Leadership Program for Physicians by Physicians to help them become better leaders in the field of medicine. Thank you so much for having me.
Wonderful. And
okay, well, my name is Anne Preston. I'm a certified nephrology nurse. I've spent my whole nursing career in the field of nephrology in all aspects: PD, home hemo, jail. I've been in center and acute care services. I left my clinical practice to join the team at Azura Vascular Care, and I'm now the senior director, and our main focus is to educate people about vascular access and the care and management of patients' access, as it is so important in all modalities of care.
You've been around for a while. How about Murat?
Hi, I'm Murat Sor. I'm an interventional radiologist. I practice predominantly out of an ambulatory surgery center in Arlington, Virginia. I'm also the Chief Medical Officer of Azura NCP, and I serve on the as a medical officer on Percutaneous, North America.
Thank you so much. I would like to remind our participants that we have the chat box, and then we have the Q&A area. If you have any question throughout this discussion, please feel free and then put your questions in there, and we will make sure that we answer it accordingly. You know, I mean, with me here, these three experts, you recognize that maybe when we have to put all their experiences together, we'll probably have about 50 years or more of dialysis experience. And so I believe that we are going to have a very wonderful discussions here. You know, I would like to start with Anne, because she seems to be the all-round person. What have you seen to be the biggest advances in access management over the last 50 years, if I should just put it bluntly to you?
Okay, so I'm sure there are a lot of people here on the call, on this in this conference who have been in dialysis even longer than I have. But I will say, when I started in the 1980s, it was kind of like the wild, wild west. Patients, I've had patients with Scribner shunts. Every patient had pretty much a graft. They're bovine. Catheters were not outpatient at all. If a patient had an access issue, they would be hospitalized anywhere from 2 to 3 weeks. And the only way they had dialysis was from a femoral access. And I mean, so that evolved over time, thank God, that, all of a sudden now patients were being discharged from the hospital, in the later 80s with catheters, which we were shocked that patients could leave the hospital with a catheter. And it then presented yet another problem, because patients are now dialyzing with catheters. Nurses' time was really involved with the care of the catheter, starting dialysis. And so for self-preservation purposes, we started catheter reduction programs, not with that title, but just because catheters were such a problem for patients and they consume so much of our time. And so as we fast forward through this, you start moving into, 20 years later in the 2000s, we are now dialyzing patients, in centers all across the country. When I first started, there were only a handful, and patients are now in the outpatient facilities. And what are we doing? Well, in the 2000s, outpatient interventional centers started to open up. We started improving the care of vascular access because these are the patients who are in the hospital all day long trying to have an IR procedure. As you move through that in 2000, we had the initiation of the KDOQI guidelines, which was the first time there were any real guidelines to direct us in all care and management of dialysis patients. So with the KDOQI guidelines and vascular access, we've now entered into another place. We have outpatient interventional services. We are looking at the patient care, but there's not been any real changes in either how we dialyze patients or access until now. We move forward almost another 20 years, which is amazing to me. There's so much technology, and now we are finally addressing even more things than in the past. So in 2019, the executive order of President Trump again brought dialysis patients to the forefront of care. And in 2019, we also had the release of the vascular access updates of 2019. Now, people in nephrology are all evidence-based. One of the physicians and practitioners are going to have their own side of the story for every guideline. But the beauty of the guidelines is they are now, outlining even additional care, and it's evoking, participation from all avenues to put in their opinion and enact different things. So that being said, in 2019's guidelines, one thing that I will take away as the most important thing is the culmination of the life plan for a patient. It is now addressing the modality choices and the access management that should go along with a modality choice. So I think that's really right now the most important thing for all of us is recognizing, how we're going to introduce patients into this renal community with a preemptive transplant, PD, home hemo, in-center, whatever the modality of choice is. But with all of those plans, it's all of our responsibility to work collaboratively to decide what access they should have to go along with it and preparing them for whatever step comes next.
Wonderful. It looks like you were able to really give us a summary of 30 years history in about three minutes. And that is great. That is great. You mentioned things like Scribner shunt, and it brings memories to me. I remember when I stepped into dialysis the very first time. That was a couple of years ago. I was working on a medical surgical floor, and that floor was dedicated only to dialysis patients. That was when I actually came in contact with graft A's and those kind of things. Patients are admitted maybe to our floor 2 days before the whole procedure actually takes place. And as a matter of fact, once it is done, you look at it as a big open wound. Mm-hmm. And today I think we don't see those kind of things anymore, but it shows us how long we have come actually with some improvement. I'm not sure if Elsie would like to add anything to what Anne has just said when it comes to access.
Yeah, so if we can look back, I love everything you said, Anne. If we look back and look at how far we've come, just think about how moving forward we can do the same thing. So it's not a matter of being. It's a matter of being forward thinking and being and learning how to be resilient in change. We can't just stay where we are. We have to continue to try and improve and push ourselves beyond boundaries that we've set, that we can see, because what we can accomplish in the future is far more than any of us can probably even imagine. If we can just form a vision where we can work together in helping patients and collaborate more as physicians and organizations beyond where we have been from a fee-for-service environment it can make all the difference in how we take care of these critically ill patients in the future. I did try to spearhead with Murat the one-stop shop initiative at Azura, where we try to get every single part of the vascular care for these patients from the beginning when they start dialysis to the time they get their catheter removed and have a working access by incorporating specialists that we didn't have before and by bringing in technology that we didn't have before. But this needs to go beyond just organizations like Fresenius. This has to go beyond just organization to organization. This needs to be everyone together. We know that doctors' shortage problem is getting to be a problem as time goes on, as more doctors are retiring and we have less coming into the workforce. And that's a whole nother discussion. We need more residency spots or ways to train physicians that are coming into medical school. But we also have a population that is growing. It's going to double over the age of 65 in the next 40 to 50 years. So how are we going to handle that? We have to be prepared right now. We have to be open-minded and resilient to change management, improving our processes, improving our workflows, making sure our physicians are taught how to be great leaders in the field of medicine so that we can collaborate and communicate in ways that we haven't before instead of just being experts in our niche. So that's my vision.
Wow, thank you very much. Murat, I think Elsie mentioned your name. It says both of you were champions in what we call the one-stop initiative. What have you to tell us about that?
Well, I'd like to say Elsie was really a key thought leader on the concept of having the one-stop shop. And we really tried to operationalize this in our organization where we've incorporated vascular surgeons with the interventionalists. We can do the vein mapping, the consultation, the creation, the follow-up and maturation if they need it in all the same site of service. And by, as Elsie has, cheerleaded over and over, we need to stop this fragmentation of our care system. And by doing that, the patient's able to move through the system quicker, and we've been able to show that we've been able to remove catheters and decrease catheter contact time. So this is really the wave of the future.
That's wonderful. That is wonderful. Yeah, and I know you were actually talking when you started, you were talking about the KDOGI guidelines and all the rest of the things. And I know for a fact that some of these things that we have actually initiated, even to the fact that we have what we call the first Fistula initiative, was to reduce the amount of catheters that we encounter in our dialysis facilities. This has been years, but then we still have up to about 66% of patients who come into our centers with catheters. What do you think we can do in order to really help with this situation? 66% is a whopping great number.
Well, I'd love to get the input of the whole group, but I think this is it's obviously a key problem that we're trying to hit from several fronts. I think there's not one solution for everyone. There's a lot of hesitancy from the patients, and they don't understand the need for a permanent access. I think that's one of the biggest barriers to getting a permanent access in people. And then when you do get a permanent access into a person, being able to, if we're talking about if we're talking about fistulas, it's getting those access used. And there's a lot of barriers after a fistula is placed till then when it is actually able to be used. And a lot of people don't believe in maturation procedures. And a lot of these fistulas after they're placed are left in the dialysis center and people are squeezing balls, and 3-6 months later, the fistula is still not being used. So I think the one-stop shop is a great way to streamline these barriers or get rid of these barriers to access being used.
Anything you want to add to it, Anne?
I'd like to add to that, all of this, the one-stop shop idea and incorporate all of these services into our access centers, I was involved with. The three of us have worked collaboratively over the years. But I think really the key thing is educating our community about all of these things and how to go about it, when to recognize problems and implement interventions, whether, like recognizing problems and fixing them as soon as you can. And that really is patient education, physician education, and the clinical team's education.
Now that we have, thank you, I'm going to interrupt you. Now that we have percutaneous fistula creation, which has come into the United States, and the reimbursement is coming and is here and coming in different modalities and different environments, we need to be able to educate ourselves as physicians to be able to educate our patients or healthcare workers, dialysis center personnel, because really, as we've discussed before in this forum, CKD patients, a lot of the time, and Murat, you and I discussed this, a lot of times they don't want to get dialysis because they don't want to have that surgery done preemptively, not knowing when they're going to start dialysis and saying, why do I want to have this major operation, have this big scar in my arm? I don't want to even start. But if they know that there is an alternative, and as more physicians and interventionalists and vascular surgeons learn how to use this other modality to get fistulas created, they can leave your OR with a Band-Aid because there's no incision. It's just it's a needle stick connecting the artery and vein together. Now that's a whole nother conversation again about fistula creations and getting them to work and working with the dialysis centers to make sure that the cannulation issues get worked out. But that's something we can do together. Europeans have been able to do it. There's no reason why we can't, as a country, come together and have this paradigm shift work for our patients.
That's wonderful. I want us to really come back to that and then discuss that in maybe a minute detail or something. But one question that I have here is, would you all agree that the coming in of the KDOQI guidelines have actually brought about consistency to the national and corporate practice of nephrology? Would you agree with me, or what I'm trying to say here is that would you agree that the coming in of the KDOQI guidelines, has helped to reshape or bring some consistency, especially with dealing with our patients when it comes to nephrology practice?
Well, absolutely. There's no doubt that the KDOQI guidelines and getting all the key thought leaders together and coming up with recommendations. And I think it's really important how they weight the recommendations with where they're sure this is going to help the patient, this is probably going to help, and we just don't know. And that's the best we can do, is to get everyone on the same page with the things that we know that are going to work and that we don't know that it's going to work or not. I think some of the recent KDOQI guidelines, which I found very helpful in my practice, is when to use stents and when not to use stents. So there was a recent information given that we can start primarily stenting the venous anastomosis and stenting in-stent restenosis with bare metal stents. And I think this type of guidance is really helpful for us, the people who are practicing in the field, to have that backup, knowing that there's research and people agreeing with this way of practicing. Go ahead, Elsie.
No, I just noticed the comments a comment that was made about the KDOQI guidelines, how the person said the KDOQI guidelines were very needed and in the broad sense very helpful for bringing greater consistency to the national and corporate practice of nephrology. However, these also can excessively produce guidelines and opinions and some old data may have been evolved and perpetuate these old ideas and block new concepts from being implemented. But the point is, we're going to evolve together. We have to start somewhere. We have to come together with a common vision and mission so that all of us can be, consistently focused in the direction that we need to go in. Obviously, there's going to be some concepts within the KDOQI guidelines which need to be worked out. And with everyone's help in working those key things out and weeding them out, we can fix that, but we need to start somewhere.
And to that note, Elsie, considering I worked for more than almost 20 years without any real national guidelines, everyone's practice evolved along their nephrologist practice. The guidelines, even though they need to be updated again, give food for thought, gives, practices direction, and everyone then can collaborate and move forward. Now, that's the exciting part of the update of the 2019 vascular access initiatives, because they have reviewed that whole component about vascular care and are giving us new direction. And I am sure that even between you and Murat, you might have differences of opinion about what to be done with the vascular access, as will all surgeons. But again, it is the opportunity for everyone to test boundaries, come up with other initiatives, look forward to the future, because all of you are part of the future of nephrology care. And with all of the advances that are going on, percutaneous is probably the most outstanding thing that I've seen in years that I feel committed to, versus life sites and all these other ideas that were just kind of, there, but didn't really change the impact on the patient. So that's kind of my feelings about guidelines. They're there to guide us, but we can be innovative and creative moving forward.
Thank you very much. And Anne, I think you mentioned a couple of things, including percutaneous, access. And I think I'm going to turn to Elsie to really ask her if she has any kind of comments you want to make on the percutaneous access. Yeah, so first of all, I want to say that percutaneous fistula creation is not a means to overcome all of what we've come so far with surgical creations, and it's not about a competition between who can do percutaneous and interventionalists versus surgeons. Not at all. In fact, it's just an added bonus of more people in the workforce helping patients. And anyone can create it. It could be a vascular surgeon, it could be an interventional nephrologist or an interventional radiologist. And what we're seeing is, if you have a patient who can't go to the OR, doesn't want to go to the hospital because of COVID or however long this pandemic is going to last, and needs to be done in an outpatient setting with minimal anesthesia, if any, or nerve block, this can be done so quickly. In fact, my quickest procedure was under 10 minutes for the ellipsis. And I had a patient, I just want to give you a story, a patient who had a catheter for 3 years and refused adamantly to have anyone touch her arm. She didn't want the scar, she didn't want anyone cutting her, but I was able to talk her into having a fistula created percutaneously, telling her that she was going to leave with a Band-Aid in her arm. And that's exactly what happened. So her catheter is out and she was able to get this fistula. Obviously, it was a little bit more complicated because her cephalic vein was closed, and interventionalists who do this every day, day in and day out, know how to fix chronically occluded veins, and I was able to open that up and get her working. So there are so many ways that we can share, we can do together collaboratively. Obviously, the payment models have kind of pushed us back in the past of being very competitive with the fee-for-service, and hopefully in the future, with changes in the payment models, it'll also incentivize people to work more collaboratively. Murat, what do you want to add?
Yeah, I did want to kind of, on Elsie's comment on the percutaneous and the additional procedures you do with them. I think the success of percutaneous really rests on the skill set of the interventionalist who does it. It's one thing to be able to place the percutaneous or do that step, but to be able to mature the fistula. Most of these percutaneous fistulas need additional maturation procedures so that they can easily be cannulated. And it takes a skilled interventionalist like Elsie to put all that effort to make sure that fistula is at a size where it can be cannulated, and then also to communicate. You can do all this work to get it mature, but not have that communication with the dialysis center. And I think that's where the interventionalist who is really good at maturation and communication can make this a really successful procedure.
That is wonderful. Before I turn to the chat and probably dig some questions from there, let me just ask, any of you can take this, Are there any special considerations when it comes to percutaneous access and how we need to cannulate it? So I could take a shot at that first. Okay. There's two different devices right now in the US, the Wavelink and the Ellipsis device from two different vendors. And you can learn either way. There's some data that just recently came out by Dr. Robert Schiaberdian in Germany, who's done close to 200 of these patients, and he also does surgical creation. So he's very unique in that he uses all three modalities for fistula creation. Now his vascular
he tries to get the radiocephalic fistula done surgically first, and that's his choice. It's best for the patient. But then when he looked at the data for the wavelength and the ellipses, it's a matter of whether they or not they have the right anatomy. And what he's found is about 28% of patients did qualify for the wavelength, and about double that amount were successful with the ellipses. Now, if you failed with either one of them, it was found that the patient can still get a surgical creation done higher up in the arm for a fistula or a graft. So there, it's amazing what we can do. It's patient selection that you have to learn how to do. And if your demographics includes patients who have been IV drug abusers or had patients who had multiple IV sticks in the antecubital fossa, then that might preclude them from having a percutaneous fistula creation. Now, if you're in a rural area where patients are a little bit more protected, or maybe they never had IV drug abuse and they never had these IVs placed, and they suddenly crash, they're crashing into dialysis, but can get a percutaneous fistula, and they got big juicy veins. I've seen patients where they can use the fistula almost immediately. In France, we know that they've been able to cannulate fistulas that are even within that specific day after the creation. So it just really depends. And Murat's right. You just have to know, you have to have the skill, but you can learn. You can learn how to do it.
And on that note, the cannulation of these percutaneous accesses, are a challenge for us all. But the thing is, cannulation is an art, and it is recognizing where the access is, being attuned to it, how you advance your needle. You're not going to always have the same response with your, insertion of the needle as you would with a traditional AV fistula, because it is a lower flow. But again, we are all competent at what we do. It's a skill set to learn, and just, rely on the resources that are around you, because these are all the things that will really improve the quality of life of our patients.
That's great. I hope nothing has changed when it comes to our own assessment. One thing that we've all learned over the years is look, feel, and listen. And I believe we all take that into consideration when it comes to cannulating accesses. Yeah, let me go to the chat box and then see what we have there. Here is a question, and any of you can actually take it. How does the panel, how do you feel, or what do you see about the future of human acellular vessels like Humacyte?
Maybe I'll take that. I'll give a disclosure.
Please go ahead.
I do work with Fresenius on the Humacyte project, so I just want to put that disclosure out there. But I think Humacyte has a lot of potential and a lot of promise. If people aren't familiar with this, this is an artificial vessel that is acellular, so it doesn't have any genetic material which will promote an immune response for the host. So this is a material that can be implanted in another human being, and it's basically an artificial fistula made of human acellular tissue. And then the body reacts by putting its own cells into the Humacyte and creates a living vessel in it. The advantages of Humacyte is that it doesn't need to be matured, so it can be reliably cannulated 4 weeks after its placement. And given that the average catheter contact time after a fistula is placed is more like 3 months, you potentially can reduce the catheter contact time by 2 months and decreasing all the associated morbidity and mortality. So this, I think, is going to be a great option for people in the future, especially if they don't have the anatomy for a native vein fistula. And it may, in fact, be an advantage for people, even if they do have the anatomy for a fistula, if it's shown that it can be reliably cannulated at 4 weeks.
Thank you very much. Elsie, anything you want to add to what Murat had just said?
I'm sorry, I was just noticing that the last comment, and I think we're coming to an end. And if I may, this person was talking about how he's seen generally the super geriatric in their 80s and 90s with permanent catheter access live many years, 3 to 6 years with no infection and complication and no hospitalization. And I think certainly there's a role for catheters in certain select patients. We talked about this before as a group, where there are patients who shouldn't get a fistula. I've had patients show up to my center with contracted arm from a stroke who's no longer alert and oriented, and now is here for a fistula maturation procedure, and I'm wondering, what am I doing here? So we do have to consider that, yes, catheters in general, we don't want to have hemodialysis catheters. We do want PD catheters, but there are some select elderly patients where we should just leave them alone.
You're very right about that. And of course, throughout our experiences, you recognize that everywhere you go, there are a selected group of patients, so a handful of them, not a whole lot, but then it also calls for us that, we always need to reevaluate patients and then see if there is an opportunity to really put in the permanent access. But you are right about that, especially the 80s and the 90s. You also don't want to trouble them that much. But if it's good for them, I believe that we will be able to really do something. Listen, we are halfway through.
Oh,
and I believe
the we're almost done. Sorry.
We are halfway through. All right. So, and then, as a matter of fact, you'll be amazed to hear that there are probably 65 people who are on this call, and I believe that the questions will still be coming. The questions will still be coming. Now, Anne mentioned something about the executive order by the Trump administration. How do we see that? Not affecting per se, but how do we see that roll into vascular access in this present time?
So if you want, I'll lead off on that.
Sure, please go ahead.
I see it as that all of the providers, organizations, the nephrology community at all are really now addressing the care of these patients before they start dialysis, having them have the ability to make choices, giving us goals for the future of how many patients should be on home hemo, who should be on PD. But it's really bringing it to the forefront of the nation that this is a population that we have not really addressed since the original executive order that said dialysis should be out for everyone. So I think it's just really putting that patient experience in the forefront and challenging us all to help these patients find the pathway that's best for them and using all of the available resources that we have. So, what either Murat and Elsie are showing us is that, there are many, many things out there that are going to help these patients, and we can all, if we collaborate, we will be more effective overall.
Thank you very much. Any other comments on that? From Murat?
I'll go next. So the executive order really emphasized that reducing the number of dialysis patients, doubling the number of transplants, and then trying to get as many people at home as possible. And I think your vascular access is the key to getting people at home. So they need a permanent access to be home, or they need a PD catheter. And I think PD catheter done percutaneously, the way that interventionalist does, is a great option for these patients and will make it more accessible to more patients. A percutaneous PD catheter can be done with minimal or no sedation. It can be done even under local anesthesia, and it can be used at low volumes the day after it's placed. So it can be used for urgent start. So I think there's a lot we can do as interventionalists to really promote the executive order. Now, the executive order went from, and the executive order makes sense because patients are happier when they get a transplant, they live longer when they get a transplant, and they're also happier when they're at home, and they do better at home. They have more freedom, and the physicians agree that this is better for their patients.
Earlier on, I listened to a presentation which tells us that the demand is higher than the supply when it comes to transplantation. But in addition to that, I listened to another presentation, the patient's experience, where he actually mentioned the fact that he has an amazing story when he mentioned the fact that not only did he have a fistula placed in, but then he also had, he says, my surgeon told me that I need a backup. Maybe I'll need a backup, where they had to actually implant a PD, what do you call it, catheter. So again, it goes to show that, when somebody is at home, that person actually does very well, because this gentleman's experience is just amazing. He has had a great time of his life. And so when it comes to these issues, I believe that we need to take the right approach in order to really bring the quality of life that these our patients actually need. when it comes to hemodialysis. It's not just going to be, you need dialysis, let's put something in your arm or let's put something in your chest rather, and then you go to the dialysis clinic. Right.
So one of the things that I'd like to say, though, when you think about these, that executive order in 2019, what followed like a year later? COVID and being locked up, locked down, nowhere to go. So the silver lining of COVID is really the ability or us trying to get patients to go home, to, take care of themselves on PD, do home hemo. The preemptive transplant, I'm hearing more and more patients, or when we visit people in dialysis units, they're saying, oh yeah, these patients are gone, they've been transplanted. Patients are not coming to the dialysis centers because they're getting preemptively transplanted. So COVID has probably been, an enhancement of trying to get more people to stay home and take care of themselves, as opposed to being in center in all of these different situations where they can be impacted by COVID.
And I also want to say that being at home on home chemo, also the data shows that the patients live better and they have less complications, just because you're not having such wide variations in their blood levels of toxins that can cause cardiac issues. So that's another thing. And I think that if we, as long as we're coaching our patients to think in this way, we'll probably have better success in having patients go home. The new data from the SIR, the Society of Interventional Radiology, there was a talk on data that came out on urgent PD versus urgent hemodialysis catheter placement, and the data shows from this one study that, and I'm not surprised, is that the number of hospitalizations and infections and morbidity from having that done was far less when you had it done through PD versus hemodialysis catheter. So I think we all need to have a paradigm shift in our minds about how we're going to coach our patients to get to choose, because they don't know what to choose. They're listening to us. They're listening to us as clinicians and they have no idea where to go next. So we're directing everything. So I think we as a group need to come together and know the data, be cautious of how we're talking about these different things and giving them the right options and telling them and finding patients, if patients say they're scared and they don't want to have it, because most of them are, then offering them minimally invasive means of getting access created.
Yeah, you hit some very important points, and for that matter, let me just redirect the question and find out what are the tidbits that you can actually give when it comes to patient education and vascular access. Because here we are, some of them don't even know anything about they went to see the doctor and say, hey, listen, you have kidney failure, and you know what it comes to. What would you say about that? What education, what are some of the tidbits you are going to give to us when it comes to patient education and vascular access?
Well, I think a lot of these patients are probably older than not, and some are elderly. So I think it's important to have more than just the patient themselves together when you're having this conversation. Now, doctors have less time to spend with patients with all of the administrative things that we have to do, including EMR. So having physician extenders in your practice to help to teach them how to do things like this will also decrease the burden on the physician, and making sure it's a family effort. Make sure, whoever the caretakers are for these people who are educated, who are learning Moyen ×3, who know what's going on, who could take notes, and having information and directing them to websites and using the internet to help them to educate our patients so that they have all the resources at their fingertips and they don't have any question whatsoever of what they're doing and what they're getting themselves into.
Murat, anything you want to add?
The major chains do have a lot of resources dedicated to the CKD patients, the early patients, for education. But I think, individual practices or the larger groups should be reaching out to whatever access providers are in their community and bring them into the fold to help educate patients, like really starting to be proactive outside of your own practice and bringing other people in to talk to the patients and their families so that they do have good guidelines about the modality choices that they have and then what access would accompany it.
Rob?
Well, so I wouldn't say that I'm an expert in education, but what I try to do with all my patients that come in with catheters is really explain to them the morbidity and mortality that's associated with a non-permanent access. And I know they do this, the nephrologists do it, I know the nurse educators do it, I know everyone who comes in contact with them, but it seems to me that it really doesn't stick with the patients. And oftentimes they're like, yeah, I understand there's a little bit risk, but I really try to emphasize that this is really for their health that we're doing the permanent access. But going back to the comment that Elsie and the person in the chat made about catheters, although I fight really hard to get rid of catheters, there are those patients who are elderly, have cancer, and they just really don't want to be stuck every day. And I think as part of the life plan of a patient and incorporating them in those choices, we have to honor their choice to keep a catheter.
Yeah, that translates into quality of life.
And the
as
dialysis center shouldn't be penalized because of them.
Then you want to talk to CMS about that.
Yeah, talk to CMS about that.
Yes, we
Speak to CMS about that. And talking about that, I hear that CMS is coming out with the new payment models. Has any of you heard about it? And can you comment on that? I mean, what are the pluses and what are the minuses of that payment method? Maybe you will have Anne take it first, or Murat, you want to go? Whoever wants to go first.
I'll start if that's okay, Anne. So yes, out of the executive order, CMS has developed these different payment models, and they're very complex. And as a friend of mine says, they're clear as mud when you try to understand them. But to my understanding, there's one mandatory model that about a third of the geographic areas are going to be made to participate, and that's the ETC model. And then there's the 4 voluntary models. But I think the underlying theme that goes through all these different models are, number one, preemptive transplant is key. We want to have optimal starts. We want to have patients at home. And then we want as low as possible per member cost of care per month, a patient cost of care. And that translates into getting rid of catheters. As we all know, a patient with a catheter costs more than 50% more than a patient with a fistula, with a person with a graft somewhat in between. So I think here's a lot of opportunity for the interventionalists, the vascular specialists to participate and partner with a nephrologist to really help them succeed in these different payment models. And we can all discuss this, but for home, the key is a PD catheter. And I think a PD catheter or a very stable place to have hemodialysis. For optimal starts, optimal start is defined as starting on a permanent access. And again, the one-stop shop, having access to a physician that's going to place it in a timely manner is really going to help us with optimal starts. But I'll roll it over to the rest of the group for comments.
And any comments on that? And you are on mute.
No, I'm just going to say, I mean, there's not much to comment other than, again, it's all about patient choices. The reimbursement is better for patients at home than not. So, so you have twofold. It's, it helps CMS having patients at home, but more importantly, patients, the studies show patients do better at home with more dialysis, whether it's home hemo or PD. And the other thing that it returns to the patient is really control over their life, like how to fit this disease process into their life that they can still have a fulfilled life with their families, maintain employment, any number of things. Where going into the center just totally ruins so much of their life and consumes so much time that, having payment models that promote this is a good thing if that's the way to get more patients to go home.
Elsie, is there anything you want to add or we move on?
Yes, I would just say that we didn't talk about this, but fistula, percutaneous fistula creation, the data in Europe shows that there's less number of procedures per patient per year when it's done percutaneously. And that's only because these are low flow, quote unquote, fistulas. And there's apparently less hemodynamic turbulence that causes intimal hyperplasia within the blood vessels. So in the US, we still need to see the long-term results, but that's promising if we're trying to cut back on the number of procedures or how much each patient, how much we have to pay for each patient to be on dialysis.
Okay, that's good. That leads me to ask this question, with all the regulations that are there, quality initiatives and everything what has been the biggest challenge in your practice? If you would just name one, and if you have all the powers in the world, what would you change in order to really make the practice a lot more, acceptable, to the renal community?
So one of the biggest challenges that I saw as an organization when I was with Azura is patients who crashed into dialysis, crash with a hemodialysis catheter, and then are not offered a fistula or a graft because they were not paid for it by the government until 90 days are up. So if I had all the power in the world to make a change, it would be the payment allowing that patient to have a fistula placed at the same time as whatever urgent means is used to get that patient dialysis immediately. So we can get them started on that permanent access from day one.
From your mouth to God's ears, Elsie.
You might be hearing.
Yeah, I mean, everyone's dream is that if, a patient is ultimately, you want the patient to have their access created before they even need to start dialysis, but there's so many barriers and challenges to get the patient to commit for whatever, whether
or even they didn't even see a doctor, maybe.
Yeah, or even to see a doctor. So hopefully your wish will be granted, because we would like to see patients have the opportunity to just show it, either be in a training center to learn to do their own care, or come into a dialysis unit and not have that hospital admission with, yet again, additional exposures to so many things that are in the hospital, that they're better off starting with us in the center than any other thing. So I totally agree with you on that premise.
All right.
Yeah, when you mentioned it, Elsie's thought came to my mind, because we've discussed it so many times as such a big barrier for us. But I guess if we're going to wish for anything we want, I'd say that if we had healthcare for everyone, then these patients, when they're having these early renal insufficiency episodes, can be tracked longitudinally, and they're going to have better outcomes. So let's push back to getting people healthcare to prevent end-stage renal disease, and as the high hope.
Okay, let me look in the chat box and see if there are no questions. So we will continue. We have about 30 minutes more to end.
30?
13, 1-3. Okay, listen, you guys have been very phenomenal, with all these discussions, and we have come from the past and we are in the present. I guess we need to roll forward and then look into the future. I know for a fact that, what we see in vascular access was not the same thing 10 years ago, or even 5 years ago. Now, so let's just go this way and find out, where do you see, with all our regulations, with everything that goes on within our society, being directed by CMS and all that, where do you see vascular access, in the next 5 years? Where do you think things are going to be? Any of you can take it on. It can be a dream. I mean, whatever. Where do you see vascular access? And especially when it comes to giving renal replacement therapy.
Well, the first thing that I think that comes to mind is that these dialysis machines are being made smaller and smaller. And I think that soon we're going to have dialysis machines that are going to be portable. So not necessarily implanted, but the patient can carry with them and they can have continuous dialysis access or over longer periods of time. And I think this is going to present a challenge for vascular access because you're going to have longer connection to the machine and higher risk for thrombosis and infection. So I think this is going to be a great advancement when we have these more portable machines for longer term dialysis, but it's also going to pose a challenge for access care.
Your thoughts, Elsie?
I think more and more people are going to learn how to do percutaneous fistula creations. Both surgeons and a lot of surgeons already do interventional work. So surgeons, cardiologists, even interventional nephrologists, interventional radiologists, whoever can do it will do it because there's going to be such a need and demand. And I think I agree with Murat that I think they already have portable machines. It's just not out there widely, and it's going to allow patients to be incentivized to say, wait, you know what, I could travel. If I learn, if somebody can help me at home to cannulate this, maybe I'll learn and I will overcome my discomfort of doing this, of needles, then it's going to incentivize them to get home hemo.
So I'm going to go to Star Trek and Dr. McCoy when he was in the, he went back into the past and he saw this patient who was going off to dialysis and said, here, do this. And then the patient miraculously had recovered kidney function. I said, I think that's kind of my dream come true, that we could figure out ways to, I know it would put us all out of business, but I would like to see less patients having to go onto hemo or renal replacement therapies, being better at diagnosing and preventing this end stage piece of the care that they receive. And that would be good. That would be my nirvana for the future.
That's good. I have a patient, and this patient, if I should say, is not somebody who's not very comfortable with needles. And so when you draw close to him, he will ask you a question, say, when will all of these things end? And his answer to it is that, he's looking to a day when you have to take a pill and you don't have to come to our dialysis unit. I said, well, you dream it, it is very possible that it could come. So we will not be surprised, with all your comments on the future of vascular access. I
also want to add, Seth, is that
Go ahead.
There's probably going to be a lot more machine learning and artificial intelligence involved with healthcare. And I think, Dr. Peter Katanko's group already has a lot of innovation underway, which probably we can't talk about completely here, and I probably don't even know half of what he's doing, but we do know that that could really help the patients in terms of being able to prevent major issues with dialysis before they happen and be able to track it without human error getting in the way, and having machines help us with the data that we're already getting from all of the machines that are already currently in use, and having them go into a computer and having the computer tell us when that patient needs to have treatment urgently, or when an aneurysm is going to burst, and be able to have that patient go see a surgical specialist immediately. So I think there's so much that we can't even imagine what else can be done, but we know it's already being done in so many other areas, even outside of healthcare, with cars driving themselves. There's so much more that we can do in medicine, and I see that even happening in the next 5 years.
It's interesting you mentioned Dr. Katanko and his group and what they are doing. Maybe his ears were actually itching. There's a question here, and I believe that the person who asked this question was not on when the same question was asked earlier on. And how do you guys see the future of human acellular vessels? Take some time to break it down so that
So we commented earlier about how it has an advantage in the dialysis space, but we didn't really talk about the other spaces that it has potential use. So I think they're doing research on its use in trauma. And the advantage of having this in trauma is that it's an off-the-shelf available vessel. And since it's a natural product, it's not like a graft material. If there's a gunshot wound or something like that, an infection is introduced into the space, the human acellular vessel has a lower chance of getting an infection when it's used in this use. So trauma, I think it has an incredible future. And then also in PAD, currently we use saphenous, or the surgeons use saphenous vein grafts, sometimes percutaneous, sometimes bypass grafts with saphenous. This will potentially be an off-the-shelf available bypass graft that's natural material, which has a lower risk of infection. So I think the future is bright for Humacyte.
Anywhere where we need a blood vessel, its potential use may be there. Maybe even for veins in the future, who knows, with valves, or for patients who need transplants and the transplant recipient's vessel is too short. You know, there's so many things that probably we're not even thinking of that it can be used for.
Wonderful, wonderful. Anne, do you have anything you want to add?
Not at this point. I think we've pretty much covered everything, and but what I will say that, you know, when Elsie started the talk, she really referenced, like, we've looked at our past, but the future is ahead of us, and there are so many technological advances that are going on. You know, implantable kidneys. Now we're talking about Humacyte. All the information that's being, you know, pumped into the computers and figuring out what's going on with each patient's dialysis treatment. I mean, the future is very bright for us for the first time. And there are a lot of things that I don't even think we can imagine what are out there for all of us.
Yeah, and I can agree with you any better than that, in the sense that if we look back 10 years ago, we recognize that there were things that, you know, we were doing that today. When we look at it, we see how improved it has become. Even if it's not for vascular access, even for dialysis as a whole, you know, look at a time when, I mean, we have to calculate our own UFR. We have to, you know, we did not even put on any gloves before we calculated. We, you know, there were things that we did not do, but then looking back, you know, you recognize that we have come a very, very long way. So in the same way, I can agree with you all that the future is so bright for us when it comes to vascular access and then dialysis as a whole. Let me take this opportunity to thank each and every one of you for an amazing discussion, you know, amazing job that you have really done. You know, we had up to 65 people who were in this forum. And of course, it goes to tell me that without them asking many questions, tells me that you guys have covered almost every aspect of the topic, which we said vascular access in the 21st century, you know, the past, the present, and the future. And I want to thank you immensely again, you know, for all the good work that you have done. Thank you so much.
Thank you too,
Thank
Seth.
you so much.
Thank you, Seth, for being a great moderator.
Thank you. Thank you. All right. So today's we bring our curtain to a close, and we want to thank all our participants, and then your questions that you actually asked. They were very, I mean, interactive, and I believe that all of you have had your questions answered very correctly. Now, I believe also that there will be a recording of this, and so if anybody wants to go back and then listen to it, that person will be free to really do that. So thank you, and we bring this to a close.
Thank you so much.
Thank you. Bye-bye now.
Bye-bye.
Bye.
Have a good afternoon.
You too.